Hi, I'm Karen Horwitz, and I'm here to talk to you today about the top 5 things that you should know about adolescent depression. Number 1 is psychoeducation. It's very important for children and their parents to know that depression looks different in kids than it does in adults. Sometimes kids can primarily be irritable or angry in terms of their presentation instead of sad and melancholy. This can often be confusing to parents who think that their child is either just being a typical teenager or has just become really angry all the time. And if you're hearing those complaints, it's a really important time to screen for depression. Also, it's important for children and their parents to know that it's nobody's fault. That typically it's not because of something that somebody has done or something that somebody hasn't done that somebody is depression. That rather, just like other medical conditions, there's often a very strong genetic predisposition to depression. And if you were to take a careful family history, you would probably find that there's somebody either on the maternal or the paternal side or several people that have also struggled with depression. The other thing to know is that there probably isn't a reason that the child is depressed. Sometimes parents will be trying to figure out, are they being bullied? Did somebody do something? Did something happen to them? And sometimes this can end up feeling very invalidating to the child who says, really, there's nothing that's happening. And this is the way it goes with something that is a medical condition. Sometimes it just happens at that point in somebody's life. It's not to say that it's not important to be sure that there isn't another cause, but sometimes there really is not another cause. The other thing to know is that if a child has moderate to severe depression, if left untreated, it can lead to increasing severity and even suicidal behavior. It's very important for children and families to know that if the child has moderate to severe depression, they do require treatment. Number 2, depression is episodic. Unlike anxiety, which tends to be persistent, depression can be episodic. With anxiety, you can think of people as having a temperamental propensity towards being a worrier, and then sometimes this can escalate to the point of having an anxiety disorder. Whereas depression is something that you can have an episode of depression, that episode could clear, and then it could return again. It is important to know that if you're depressed as a child, it is more likely to be persistent throughout adulthood. Because it's episodic, there's going to be different phases to treatment. During the active phase, you're going to want to include medication plus therapy if the depression is in the moderate to severe range. Typically, we treat for 6 to 12 months until you have symptom remission. If you don't have a response in the acute phase, it's an increased likelihood that you're going to have relapse in the first 5 years. The research has shown that this can be up to 70%. So you really want to work to have remission of the episode of depression. During the maintenance phase, you'll have to determine the treatment based upon the severity of symptoms. I would say that during the maintenance phase, sometimes you use therapy, sometimes you don't. Sometimes you use medication, sometimes you don't. If you have the following symptoms, you're going to want to keep the medications for greater than 6 to 12 months, including if the child had psychotic features such as delusions or hallucinations, moderate to severe suicidal ideation or behavior, moderate to severe functional impairment, if they were resistant to treatment, or if the symptoms have persisted for greater than 2 years. If the patient had an unsuccessful attempt at tapering their medication, or if the course of illness includes 3 or more episodes of depression. Throughout this time period, you're going to continue therapy as needed, depending on any persistent symptoms, or if the patient is continuing to struggle with relationships or coping. Number 3, black box warning. All of us are familiar with the black box warning that was issued regarding the use of SSRIs in adolescent depression. What's important to know is that the United States Food and Drug Administration put together an advisory panel that reviewed 24 different studies, including 4,400 depressed teenagers. They looked at both suicidal thoughts and behaviors in kids treated with SSRIs. What they found was that response to treatment occurred 11 times more often than a suicidal event, and remission, which is a more stringent outcome than response, occurred 4.5 times more often than a suicidal event in those kids treated with SSRIs. It's important to know that in this study reviewing 4,400 teenagers, there were no completed suicides. Following the black box warning, SSRI prescribing decreased by approximately 18 to 20%. In the same period of time, the rate of suicide in children and adolescents increased by 18%. This was the first increase in suicide prevalence in 10 years. The way that I understand this information is that the risks of not treating are far greater than the risks of treating. Number 4, initiate an SSRI. What we know is that for moderate to severe depression in adolescents, combined treatment, meaning therapy plus medication, is the most effective treatment. Prior to initiating a medication, it's really important to take a full family psychiatric and medication history. It will be important for you to know whether there are family members with bipolar disorder, depression, anxiety, and if so, what medications were effective and which medications were not effective or led to either severe negative reactions or side effects. When making my decision about medication, I take into account what first-degree members in the family have responded to, and sometimes that can be a really useful way to make a choice. But generally speaking, our first-line choice for teenagers with depression is fluoxetine. Our second-line treatment would be sertraline or escitalopram or citalopram or venlafaxine. Our third-line treatment would be bupropion or duloxetine. It's important to remind children and their families that these are not magic pills. These pills are not going to dramatically change who they are. In fact, many teenagers are relieved to know that these medications are not going to dramatically change who they are as a person. But I always tell them that hopefully it will bring them to a happier version of themselves, and that it will take at least a month to see a benefit. The most typical side effects that I see with kids are a dry mouth and an upset stomach. However, it's always important to let them know about the risks for more serious side effects like a manic or a hypomanic episode. And what I always tell them is that if they notice any side effects at all, or if they have any concerns, or if in any way they feel worse instead of better, to please be sure to let their parent know and they can give us a call. Number 5, evidence-based psychotherapy. Because for moderate to severe depression, therapy is an essential component, it's important for you to know which therapies have been shown to be effective for teenagers. The first treatment is cognitive behavioral therapy. This therapy looks at the connection between thoughts, feelings, and behaviors and helps teenagers to break cycles of negative thoughts and the ways that this may lead them to behave in certain ways that lead to certain feelings and how you can break that cycle. Dialectical behavior therapy is a treatment that's used for suicidal adolescents. This treatment combines CBT, cognitive behavior therapy, with Eastern religious philosophy to help kids both look at the ways in which they need to change and being able to accept where they are. This treatment really focuses on helping these kids to create a life worth living. The other type of treatment that's been shown to be useful for depressed adolescents is interpersonal psychotherapy. With this treatment, it focuses on things that the teenagers can do in terms of their relationships to decrease the amount of depression they have, increase their behavioral activation, and improve their relationships, both with peers, other adults, and with their family members. For some kids, you may find that it's going to also be important to consider family therapy. It is very important also when you're making a referral to keep in mind that even if the child is engaged in individual therapy, that the parent should not be excluded from the treatment. It's really important for you as a parent to know what is happening in your child's treatment so that you can support that work at home. Unfortunately, we're in a phase where the prevalence of depression is increasing in adolescents and is increasing in female adolescents disproportionately. It is very important that when you're doing your screening that you are speaking with these children and families about initiating treatment. If ever you have any questions or concerns about how to do this, please remember that we are here to support you through PDPRN.